great pleasure to be with you today. I'm Jean-Yves Reginster. I'm the director of the WHO Collaborating Center for Epidemiology of Musculoskeletal Health and Aging, and I'm also a professor of medicine at King Saud University in Riyadh in the Kingdom of Saudi Arabia. And the objective today is to discuss with you how we can best use bone-forming agents in the management of osteoporosis. So we'll try to identify the osteoporotic patients who should benefit from a treatment with bone-forming agents. I would like to help you recognizing the pros and cons of the currently available bone-forming agent, and eventually we should be able, after this meeting, to explain how to use bone-forming agents in daily practice. The management of osteoporosis, the paradigm of the management of osteoporosis has dramatically changed a couple of years ago when SKO recommended that treatment should not be a one-size-fits-all approach, but should be based on the baseline fracture risk of individual patient. And as you can see here, patients at very high risk or imminent risk for fracture should receive as background first-line therapy anabolic agents followed by anti-resorptive treatment. Today, we have two groups of bone-forming agents. The first one are the parathyroid hormone receptor type 1 agonists, which include teriparatide and abaloparatide. There is a difference in their binding to the receptor in the sense that teriparatide predominantly binds to the R0 conformation of the receptor, while abaloparatide predominantly binds to the RG conformation of the receptors. And as you will see, this translates into a shorter binding for abaloparatide, which has clinical consequences that we will see in just a moment. The other bone-forming agent currently available is romosozumab, which is an antibody neutralizing sclerostin. As you know, sclerostin inhibits bone formation by blocking the Wnt signaling. Romosozumab neutralizes sclerostin and subsequently allows for increased Wnt signaling and increased bone formation. I mentioned that there is a difference between teriparatide and abaloparatide, in the sense that, as you can see, because of this preferential binding of abaloparatide to the RG conformation of the PTH1 receptor, there is a less important increase in bone formation and in bone resorption with abaloparatide, but the net difference between the increase in bone resorption and the increase in bone formation makes it that abaloparatide has a greater anabolic window, provides a greater benefit in terms of net bone formation compared to teriparatide. As you can see, both of them, teri and abalo, increase bone resorption and bone formation. That means that they are on the remodeling side. Opposite to that, romosozumab works more on the modeling side with a short, transient, but important increase in bone formation that vanishes after roughly 2 months, but there is maintenance of the anti-resorptive agent. So we could even consider romosozumab somehow as a dual mode of action compound. So what are the key messages? The key messages are PTH receptor 1 agonist and Romo reduce fracture at all skeletal sites, and they do that more than anti-resorptive agents do. Compared to teriparatide, abaloparatide has a greater and faster anti-efficacy for major osteoporotic fractures. This was shown in their pivotal study, active call, non-vertebral fractures, in real-world evidence studies and in network meta-analysis, and on hip fractures in real-world evidence studies. Today, if we compare the two classes of drug, Romo and PTH1 agonist, there are no data that suggest a difference in fracture reductions between the two groups of drugs taken as a whole. All bone-forming agents should be used as a sequential treatment and should be followed when they are stopped by an anti-resorptive agent. Otherwise, the benefit obtained from the bone-forming agent vanishes in a couple of months. In patients who have been pre-treated with a potent anti-resorptive agent, romosozumab shows a quicker benefit at the hip compared to teriparatide. There are no data available currently for abaloparatide. And eventually, providing the guidance from the FDA or of the EMA are respected, which means that Romo should not be prescribed to patients who have a history of cardiovascular disorder or who are at high risk of cardiovascular disorder. All bone-forming agents are very safe compounds, including regarding their risk of cardiovascular events. So I thank you very much for your attention, and I hope that you are now ready to use bone-forming agents in patients at very high risk for osteoporotic fractures.